giving you some easy ways to look at the case in case you're seeing it in your outpatient and making a diagnosis. I'm going to divide my talk mostly on the role of pediatric retinal infant imaging, pediatric or infant. Mostly we're going to deal with children less than a year now in the photographs. From a diagnosis, how to monitor treatment, a little bit about OCT, but that's a separate instruction course. Fluorescent angiography, and then I just want to share some very early experience in using the OCT angio. So the wide field digital imaging system we use for infants is the RetCam. All of you all are aware it comes with different lenses. Majority of the work is done on the 130 lens or the 120 lens, and that's given the name of the ROP lens. I have no financial disclosures to make in any of the product, software, or the analysis tools that we've been using. So let's, in terms of documentation and diagnosis, the best way to do it is to look at some conditions. Coats, as we'd want to imagine it to be just subretinal exudation, sometimes it presents almost like an FEVR-like pathology. So that's when you want to differentiate it. Active retinal exudation, subretinal cholesterol, and if you have the access to the angiogram, then the so-called light bulb, which is the telangiectatic ending of these vessels, is sometimes a giveaway. Now what's important is exudative retinal detachment also shows up in coats, and although may not be very common, when this does happen, it gets quite easily confused with FEVR. Although we want to believe coats happen only in male children and unilaterally more often than bilaterally, all these are exceptions to the rule, and then you'll always have different conditions. So it's important to understand that exudative retinal detachment can be part of the cohort. An epiretinal membrane at almost any pediatric population should first direct you to a differential diagnosis of a combined hamartoma of the retina and the retinal pigment epithelium, or the CHRRPE lesion. But often it is not the very full-fold diagnosis that you see like this, which is fairly easy to make when there is a pull-out, a traction, a disc drag, and then even a mushrooming of the retina just underneath it. Often it is just a serendipitous discovery. For example, in this 7-week-old baby who was getting screened for routine ROP, we found this lesion, and then we've reported this to show how early staining of that lesion, not leakage, and how that lesion can be picked up on an OCT as well. So it's important to understand that small lesions can be combined hamartomas, can be retinal astrocytomas, and a lot of these have syndromic associations. So it's important to look at these patients in that perspective. Schisis is going to be dealt with Dr. Dogra, so I'm not going to spend too much time here. Just to say that, again, the atypical presentations of the schisis would be vitreous hemorrhage and vitreous veils. A lot of these schitic babies have been followed up in adulthood, and a few of them have atrophic foveas. So you see adult patients who have subnormal vision with ophthalmoscopically so-called normal-looking fundi. Often they have suffered from schisis that has caused foveal atrophy. So this is again one thing we want to remember. FEVR, again a separate topic by Dr. Subhadra, will not dwell there. She's going to be there in detail. It's called many times the full-term babies with ROP. In our country, with genetic studies not coming in so strongly, and with heavier babies developing ROP itself, sometimes there is a gray zone on whether this is atypical ROP or FEVR that's not been classified. But what's important here is that the coats-like reaction to FEVR is important to know. The other thing that we want to remember in FEVR is that it is a lifelong active disease. We've seen a very unfortunate case that has had very successful lens-sparing vitrectomy done by Dr. Tracy, who had a very common viral conjunctivitis, and that viral conjunctivitis led to a full-blown recurrence of the retinal exudation, and that was the better eye, and then went into exudative RD, and then that eye was lost. So even trivial infections like regular conjunctivitis can sometimes precipitate the retinal vascular process. This has been reported. So it's important for the parents also to understand that FEVR, unlike ROP, doesn't have such a nice natural history where once you laser or once you give a definitive ablative therapy, the disease is going to go away. The other thing about FEVR, at least in India, and if we understand this as a disease with the spectrum of the Wnt pathway. So the Wnt pathway are those genes that code for retinal angiogenesis. So when you're talking about abnormal vascularization, on one end you may have coats or coats-like or the JFT-like lesions, and on the other hand you have completely dysplastic retinas, which is the Norie's disease. And people have shown that you can have a phenotype-genotype combination. So you can have a genotype of a Norie's but a phenotype of FEVR and so on. So it's important to understand that these are abnormalities along the Wnt pathway, which is coding for abnormal angiogenesis. So anywhere along the path, depending on how and where that arrest has happened, you may have different phenotypes. So a double falciform fold is another feature that you can see. A very, very vascularly active NVE with amazing amount of ischemic retina is the other thing, and dysplasia is the other thing. But the most classical one that we know FEVR to be, especially the cicatricial form, would be that which is the falciform fold. Persistent fetal vasculature syndrome, previously called PHPV, often gets misdiagnosed or confused with FEVR. So I'm just going to give you a few pointers in the outpatient how to differentiate the two. So one of them would be possibly the eccentric cataract, either because the stalk is coming to the retrolenticular space or the primary pathology itself involves the lens. And then you have the smaller globe. So let's look at that. A PFVS versus FEVR, a smaller globe, unilateral. Dysplasia can happen more in FEVR. The stalk, of course, but the one important clue is to depress and look at the pars region. If the pars plana is poorly developed or not developed at all, it is likely to be PFVS and not FEVR, because in FEVR you would have a fairly normal pars plana. Norie's disease, not very commonly reported in India, but the key word is dysplasia, and when you see dysplasia, it would be Norie's. MPPC, a more recently described syndrome, microcornea, posterior lenticonus, PHPV or PFVS and coloboma. Often, as ophthalmologists, we understand that these conditions have syndromic associations and a lot of them have a cerebral problem. So you have to refer them for multiple care. Again, this picture is so that we are alerted as ophthalmologists that once you see a lesion like a capillary hemangioma, remember that they can have central nervous issues, and they have to be co-managed by your pediatric colleague or a pediatric neurologist, like in the WM syndrome or the Sturge-Weber syndrome. Imaging in terms of role of monitoring treatment, I shared this case yesterday. So this was a case where a partial ROP laser was done and we were waiting for some amount of the posterior pole to vascularize. We put in some supplement laser knowing fairly well that this ischemic retina needs treatment. The mother of this child was a VR surgeon who was supposed to show up a week later but missed 2 months of follow-up and then ended up with this band. So when you have a diagnosis like this, you don't know what to do. Is it lens-sparing vitrectomy, further laser, or even the more daring anti-VEGF? So anti-VEGF perhaps not, because there would be a crunch. Lens-sparing vitrectomy may have been a good choice, but the mother did not agree. And so we eventually did some more laser, using the secondary posterior laser about 2 disc diameters from the center of fovea. And this baby is now about 6-7 years old, doing well. And the indication for it to you understand it doing well is because this is still hemorrhagic and it's not fibrotic. So if the post-menstrual age is more than 40 and it's got more fibrotic bands than hemorrhagic bands, it's not going to respond so much to your laser ablative therapy. Also monitoring a post-surgery. So lens-sparing vitrectomy for 4B, pre and post-surgery, is very obvious and how that works. And I'm going to let this a minute video play on how you can monitor progress after anti-VEGF. So the APROP does well. You can see this is a montage, so a massive amount of the periphery is avascular. 4 days, the plus is coming down, the vascularization goes further, 1 week, 2 weeks. I just want you to keep your eyes on to 8 or 10 weeks, when what happens is you see a recurrence. Now, even the BEAT ROP study showed that recurrences can happen as late. So that's 10 weeks, you can see early NVE, and then by 11 it's actually bleeding. We should have lasered it at that time, but child misses follow-up. You can see the hemorrhage superiorly, and then it's lasered. So 12 weeks after injection. So this is important. You monitor this. It's only then you can pick up these early changes. This child does well because of then adding on this laser. For those of you who are giving Avastin as monotherapy, remember that the follow-up is supposed to go on for almost 2 years. So if the patient and you are not prepared for it, it may be effective in the beginning part, but later if you don't follow up, these recur and they can actually detach. Just a little bit about angiography. To demonstrate that, there's just going to be this interesting case of incontinentia pigmenti, very obvious with the pigmentation on the skin and the axilla. Now, what's important here is the neovascularization, which is fairly obvious clinically and on the angiogram itself. But what is important here is the other eye, I don't have the picture here, looked almost normal, but had a small NV inferiorly as well, which may have been missed out clinically. So IP is a bilateral condition, and to expect it to be asymmetric is okay, but to expect the other eye not to be involved at all is kind of not usual. Now, to illustrate the use of angiogram after post-Avastin cases, this baby was was given Avastin and laser in another state, came for another opinion. 9 months of corrected age, mind you. This is almost 10 months after the injection and the laser. And what you see here is, you'd agree that the laser is not complete. And then when you look closely, you still see an active band of neovascularization. I mean, how uncommon is this if you had just lasered the baby? If you laser the baby, you see a very predictable natural course. It does so well, the NV goes, the disease goes away, and then you have a predictable course in following up these babies. But after Avastin, the entire natural history itself changes, especially if you then do inadequate laser. So there it is. You can see a sort of NV band here, a little more fibrotic. So we decided to do the angiogram. It's very obvious it was leaking, and the skip areas of the laser, again very obvious. So I'll just play this quickly. Again in both eyes. In the left eye we saw that only the inferior temporal was very obvious clinically, but in the angiogram you realize how much of the NV is actually leaking. You go ahead and do a post supplement, and then we have an angiogram post that is doing very well. So again, angiogram can be used to monitor both treatment, both plain after injection or even after injection, to see where supplement treatment can happen. And then you see the fovea and the FAZ also develop quite well. This is the supplement done, and then in the periphery, and supplement done in the periphery and then doing well. Just going to end with SDOCT. Again, describe the effect with this same case of tuberous sclerosis. Ash leaf spots. The child presents with seizures and comes to you with a diagnosis of possible tuberous sclerosis. In fact, the skin lesions were not even noted by them, and we actually looked at on hindsight after we saw this in the eye. So it's a classical hamartomatous lesion in the right eye. But on closer inspection, you actually see another lesion here, and then a third lesion in the left eye inferiorly. And this third lesion in the fellow eye is actually bigger than this lesion. So what's curious here is the way the OCT and the angio have a play between each other. So the OCT in the right, very obvious lesion, is showing some undulations of the inner retina with a possible vitreomacular-like traction. So it's obviously the hyaloid's getting lifted off there, and there's some changes happening here. The other lesions are much more smoother, and there is no vitreoretinal interface interaction. Now, how does this play out in the angio? In the angio, you find that the lesion which has the undulations and the VR traction stains in the lesion, and there's mild amount of leakage at the end in the late frames. But those that have a smooth contour do not leak. So here is a lesion which is, especially the right eye superior lesion, which is almost not clinically evident, is not being picked up on angiogram, but picks up on OCT. So again, you must have a high degree of clinical suspicion and then drive your imaging to possibly pick up that. Now, OCT angio, a very, very early experience, just 2 or 3 weeks in our institute. I put these images more to learn from the audience than to actually share something new. This was a case that has been lasered, and we want to go closer. We understand there's some ischemia, and we're wondering how to do that. How close to go, because the fovea is still not fully developed. This postmenstrual age is still about 33, 35, and then you see these ischemic pockets. You want to go this close, but you're wondering whether you need to do that in the first shot or not. So a week later, you get this ridge, which is very close to the possible destined fovea. You do run the OCT, and you realize it's less than 1 disc diameter from that ridge. So we tried the OCT angio both before and after supplement. So 2 things we noticed. One is, of course, we are looking at this sketic-like inner retinal edema, which has been described in the time domain era. It has not been described in the ischemic retina as much as it has been described in the post-lasered retina. So this is interesting, because we're looking at this portion here. We're looking at the section has gone through this portion. So we're looking at this part here, and we're looking at a large sketic area with, after a little bit of supplement, you notice that I've gone a little bit here and here. And then a week later, the schisis goes away. What's important here is we are able to map the NVE. You see the superficial NVE here. And when you look at the en face, this is superficial, deep outer retina and the choriocapillaris, and you look at the NV here, which you cannot trace deep. So this is a superficial NV picked up on the OCT, and then deeper you actually look at the vascularization of the so-called feeding vessel. We're waiting to pick up follow-up scans on this, and we hope that we'll be able to use this tool to actually monitor this. So I think non-invasive and non-contact methods are the future, and many more speakers are going to deliberate on individual conditions. Thank you very much.